Familiar with this, with hepatitis C, about 40% right now with the had cirrhosis of the liver. The cirrhosis can give rise to hepatocellular carcinoma, cancer of the liver, and that will happen in roughly 3 to 5% of these cirrhotic patients. Now, what we want to do is to interrupt the natural history of this, and even in those who have cirrhosis, some of them will actually resolve the cirrhosis if it's not very advanced, can even resolve it. But regardless, we want to identify who has it, and we want to treat those who have it. Now, that's easier said than done, and we'll talk about what the barriers are. The barriers aren't that we don't have effective treatment. That's not the barrier. But these barriers are being overcome, and many of you know what I'm talking about. But when you look at this slide right here, what you're talking about, this is cirrhosis, and this is 10 years old. It's still going up. Related to hepatitis C, this is from a big VA study. These are people who decompensate. These are the ones who often will go to transplant, and these are the ones that get hepatocellular carcinoma. But that's all going to change as we eradicate this disease. Okay, now, what was put out initially by the CDC, by John Ward, who's the director, was a policy that unfortunately has not been very successful. What that is an attempt to identify people who have this disease now, because in the United States, there are probably around 5 million people with hepatitis C, and over half of them have not been diagnosed. In the world, and whenever you say the world, the data is sort of soft, but it's estimated somewhere between 170 and 180 million people. So, number one, let's identify who they are, and two, let's try to treat those who have been identified. So it's a little easier said than done. But the policy focuses on the fact that if we look at those people in the United States who have hepatitis C, 80% of them fall in a cohort where they were born from 1945 to 1965. So they're 51 to 71 right now. Why? Why are 80% of the people in the United States in that cohort? And I think most of you know this, this is the baby boomers. And if we go back in time, particularly around the Vietnam War era, young people were experimenting with drugs. They had no idea they were getting hepatitis. The reason they didn't know is hepatitis C typically doesn't present with jaundice, like an acute hepatitis B would. So they didn't know that they were messing around with needles. And these people weren't hardcore drug addicts. Some were, but most of them weren't. They were young people that went on to college in many cases, became blood donors, and over the decades, insidiously were developing chronic hepatitis C. So the reason for this age group you want to test is you don't have to say, did you ever inject yourself? Listen, when the doctor's writing now, oh, he injected, you think they're going to tell you that? And they're going to say, well, that's something I did 30 years ago. What's that got to do with now? So the whole thing is resolved by saying you were born between 45 and 65 and you should be tested, period. That's all you got to do. Now, unfortunately, that doesn't happen the way they wanted it. The way they wanted it was that if someone touched base at any health facility, whether it be in an outpatient setup, an OB setup, test them once if they were born between those years. It's not happening like they wanted it to. So all I can tell you here is remember that when you see someone right now who's between the ages of 51 and 71, they've never been tested, just test them. And tell them you're doing what the CDC has asked. Okay, fine. Now, Obviously, you're going to test people who tell you they had a risk. If they ever received a blood product, particularly before 1992, most of these people got blood products back in the 70s and 80s. For example, let's take a woman who had any kind of GYN surgical procedure. They routinely hung up 2 units of blood. No one realized back then that that could cause hepatitis. So, blood products before 92, anybody that injected themselves, anybody that told you they were jaundiced, and there was no good explanation. Now, when you get them, when they are found to be positive, what you're really testing for is antibody to hepatitis C. Some of those people who have antibody do not have the virus. Some of them rapidly cleared it, and they don't have the virus. If you treat somebody successfully with C, you'll get rid of the HCV RNA, the virus, but the antibody will be persistent. So when you have antibodies positive, you then have to get HCV RNA. And all of those steps, you can lose people. What they're doing now is, and we're involved in this, testing with what's called point-of-care testing, where you can take blood and put it on a little pad, and within 45 minutes know do they have hepatitis C. That's antibody, but if you saw that in your office, you then order HCV RNA. Moreover, they're now doing point-of-care testing for HCV RNA, where you could say, okay, this person has antibody, we're going to put a drop of blood on this other pad, and they have HCV RNA. That kind of screening will go on in parts of the world where they can't go to some healthcare facility. They may be out on the desert somewhere. But regardless, when they have HCV RNA, they have hepatitis C. So that's the next thing. First hurdle is identifying. The next thing is to be able to get medication for them to treat it. And that's the next hurdle. But when you find they're HCV positive, look for other things. See if they have had problems with the sauce, with booze. Now, let's put that in the proper perspective. You know, 1 to 2 drinks a day is good for the corazon here, the heart. That's been my rationalization. But you're talking about somebody that drank heavily and you want to counsel them appropriately. But the main thing is you want to get them treated. Okay, now what we're talking about when we say treatment nowadays, and you've seen variations of this, and I'll update it in the next couple of slides. In the past, we treated with interferon and ribavirin. And that was fraught with side effects. And you had to spend a lot of time in monitoring these people for side effects. Moreover, most of them weren't cured. Fortunately, we're now in a time when we really don't use that regimen at all. Some people still use components of it, but we're talking about combination of direct antivirals. Now, what's the difference? Interferon and ribavirin are stimulating your host immune system to attack the virus. Direct antivirals go right to the virus. And there's 3 very attractive sites that you want to inhibit. One's called the polymerase, one's called the NS5A area, and the other is called the protease. And you see them outlined here. You see NS5A. NS5B is the polymerase area. Over here are the proteases. So it's combinations of a polymerase inhibitor, this is the most commonly used one, with a NS5A inhibitor, with a protease inhibitor if you're going to use triple therapy, but now you have various combinations of these. You usually have to have at least 2. Okay, now let's see where we're going. What's out there now, where we're going. Okay, what's out there now is this polymerase inhibitor here, coupled with an NS5A inhibitor. The one called, I'm not going to get commercial names here, but the combination of sofosbuvir and ledipasvir right now is the most commonly used one. But there are other combinations. Now, there was a combination of this protease inhibitor with the polymerase inhibitor. There is more recently combinations of this protease inhibitor with this NS5A inhibitor. There's a combination out there with a non-nuc polymerase inhibitor that's licensed, together with this protease inhibitor and this NS5A inhibitor. So you've got, which is good, it's healthy. You've got a lot of competition. You've got at least 4 different pharmaceuticals. Now, one is way ahead because they started first, and it's a traction. But each of these is efficacious, and you'll see the various track records. It's good, though, that there's competition. Now, what's going to be coming out very soon? Very soon, you're going to see this NS5A inhibitor, valpattosvir, combined with this nuc polymerase inhibitor. That will come out the end of this month. That has the advantage that this NS5A inhibitor is what we call pangenotypic, and more pangenotypic than the one that's out there. But look what else is coming out here. Not tomorrow, but you're going to have combinations here of new protease inhibitors and NS5A inhibitors, which are looking promising. This is a protease inhibitor that will be combined with this and this, and we're studying that now as more of a salvage treatment, people who failed previously, but that'll eventually be out. And if you're looking at earlier studies, you see them here, we won't talk about that, but we'll try to talk about what you have and what's coming out soon. This is what you have now. This one here will be coming out in June, this combination. And what you see is what the components are. This is finishing up. We did this, and it's exciting. It's coming out the end of this month. This is that other combo we talked about. It's phase 3, so it'll be coming out, and you can see here, you got a polymerase inhibitor, you got an NS5A inhibitor. This is again coming out. Right now you have, and we talked about this particular combo with this drug and another drug that is a NS5A inhibitor. Okay, now let's look. What's the problem? Okay, so now we've identified the people. Well, our next problem is getting a drug for them. This is easing up. But when it first came out, it was very difficult to get it because the drugs were very costly. With competition, there are many more discounted drugs, more competition. Now, what's a good example, and I like it, probably was for the wrong reason, but I like it, is take the Veterans Administration Medical Center. Well, they had some bad publicity on appointments, etc. So what are they doing about hepatitis C? And there are 135,000 veterans with hepatitis C. You know what they're doing? They're treating all of them. And I like that. Whether it's mild, moderate, or severe, it's federal, and they're all getting treated. That sets a very good example. Because what has happened in this argument here between the provider, who is you, and the payer, were guidelines. Now, the guidelines originally came out, and they're still there, but they're changing, from the American Association for the Study of Liver Disease and the Infectious Disease Society. I couldn't stand these guidelines. Now, look, the ASLD, I used to be president of it. My father was the first president, and I told them they stunk, and they did. Let me tell you why. They caved into the payers. That's over. What is the indication for treatment? One thing, if they have HCV RNA, that's the indication. And there's all kinds of evidence that even these people with mild disease benefit. They function better in society, they feel better. At the other extreme, you have people, obviously, you want to treat, you'd like to have treated them earlier, people with cirrhosis or decompensation. But the whole spectrum should be treated. Now, payers will tell you, look, we have so much money, etc. I've looked at some of the reports of these payers. They're making $4 billion. I mean, you know, I'm not crying for it. But anyway, regardless, you have to be realistic here. And many of the payers now are coming around. A good payer is Medicare Part D. Other companies like United Healthcare, they're coming around. Aetna's coming around. Cigna. There's one that's holding out. I'm not going to mention it, but I'm upset with it. Now, the tough one would be a Medicaid patient. That's the tough one. And obviously, we've got to treat these people as well. Worldwide, what you're seeing is you're seeing generics being made that actually work. They're not licensed here. You see some of the big companies have given drug to areas that are poorly developed, that really need it, etc. And there are sites now in the world. One good one is Egypt, that has 15% of their population with hepatitis C, that now has big treatment programs with a polymerase inhibitor and an NS5A inhibitor. You have target areas like in Mongolia that they've given the stuff to. In Belize, Georgia, and Georgia. Who's been to Belize, Georgia? Who was born there? Stalin. Okay, I've been to Belize, Georgia. These guys have big swords and they're dancing around, you know. They drink wine out of the horns. You need to go there. Anyways, but they're curing them in Belize, Georgia. 5 million people. There's a lot of sea there. So they're targeted. What's going to happen? Remember what I told you. You're going to see eradication. And it's going to be, it has the endorsement of the World Health Organization and every liver association. The European Association, the American Association, the Latin American Association, and the Asian Association. So it's going to go. Hepatitis C. Okay. This, I'm not trying to promote, but you should have one of these. I keep it on my iPhone. And it's a way, it's an app. And it's a way that given a person with C, if you hit that start thing over there, it'll ask you one. Is this person treatment experienced or treatment naive? Does this person have cirrhosis or not? Does this person have genotype? And it'll ask for the genotypes. And when you put each one of those things in, it'll give you right now what has been licensed for treatment for that genotype with or without cirrhosis, with or without previous treatment. Very handy. I keep it with me because it's gotten so big now with all the different ones, you got to look it up. But it's very handy. Now, let's look at the more recent guidelines, and this is constantly changing. And this is just for genotype 1 because it's the most common, but it's got all the genotypes. But let's take it right now. Right now, this one, this combination, I'm going to mention the companies just so you know it, so see how many are doing. This is Merck's, this is Gilead, this is AbbVie, this is Janssen with Sovaldi, sofosbuvir, and this is Bristol Myers. So you got all these companies, and this is for genotype 1A, and the specific recommendation, you notice what we're cirrhosis. We got a screamer back there. What happened? No, okay. I thought there was a baby back there. Okay, now, it's taking in is he getting credit for this, CME credit? Okay, anyway, now, let's get, here's 1B. 1B, you'll notice, in general, does better. They all do well, but I mean, as far as having an indication with other drug combinations. The same kind of thing, 1B. Okay, what the big issue is, remember this. It's going to be, if you have to give it more than 12 weeks, they're going to fight you on it. And they'll say, add ribavirin, often the data will be there. Well, some people can't handle ribavirin. It causes a hemolytic anemia, and particularly in Florida, where people are older, even though 80 is pediatric here. We know, but listen to me. You got to be careful there, because you get a brisk hemolysis in somebody of that age, you can have serious problems with coronary artery disease. Okay, so now look right now at the tougher groups. The toughest group right now is genotype 3, cirrhotic, who failed previous treatment. Already I'm losing a person here. Huh? Oh my God. Okay, listen. Now this is the toughest group. That's the extreme. That's why I'm putting genotype 3 up here. Genotype 3 is prevalent in India. We see it in the United States, but it's the predominant one in India. And if we just look at genotype 3, and that's why I'm picking it out because it's a tougher one, and in this situation, it's a combination of sofosbuvir and one that's coming out at the end of this month, Hepatitis. And let's look here. Overall, with that combination, you had 95% cure. That's overall. No cirrhosis, looking good. Now this is comparing it to sofosbuvir and ribavirin. Forget that. You're going to give a combination of two direct antivirals if you can. But so let's look at the blue ones. No cirrhosis. Then you get into cirrhosis, it drops down. If you look over here, treatment experience, because these are treatment naive, now we're getting tough here. We're down here to about 89% cirrhotic treatment experience. That is relatively good for genotype 3 cirrhotic failure to clear on a previous treatment. Now, but 89%, we used to think that was great. Right now, if you came out with a new drug for C and you had less than 95% cure, you're out of business. You can't even get in there because in the vast majority of cases, it's going to be greater than 95%. So that's genotype 3, and that's a newer drug coming out. Now, this is that same one that's coming out at the end of this month, and this is all the other genotypes. On here, 3 looks terrible, but the numbers are very small. But let's look at these other combined here, okay? Let's look at it. These are other genotypes. We're looking here at 12 weeks or 12 weeks plus ribavirin or 24 weeks. Now if we go over here, and remember here we got decompensated cirrhosis. So that's an extreme of advanced disease. These are people who would be on a transplant list. And if you're looking here, it's looking pretty good here. Looking pretty good, but these are those other genotypes. This one, the genotype 3 one, is the tough one. This is a much smaller set of numbers than what I showed you before. But it's still the challenge. Okay, so let's look now at, in this case, this is genotype 3. This is out now. This is diclotsavir plus sofosbuvir with ribavirin, genotype 3, with advanced fibrosis or cirrhosis. So advanced fibrosis is bridging fibrosis. So let's look right here. What do we have here? This is overall somewhere between 90 and 100%. This is overall. This is with advanced fibrosis, not quite cirrhosis. This is cirrhosis. If we look at the duration, now this is important. Here you see 12 weeks, and if you look at these two, this isn't great. I mean, it used to be great, but not anymore. If you look at this, where they have cirrhosis, and you are going for 16 weeks in this case, that's what they're looking at rather than 24, it's better. Now, as soon as you say more than 12 weeks, they're going to fight you, even though the data is there. Some people just can't take ribavirin, and in some regimens, it's going to be 12 weeks plus ribavirin or 24 weeks. That's why they're trying to go 16 to make it a little more palatable. It's cost, it's not safety, it's cost. And those are the things you have to deal with. But ribavirin, many people can tolerate, but you got to watch them for side effects, particularly a hemolytic anemia. Now let's look at this. We're looking here at another product altogether. This is out here now. This happens to be the Merck combo, with or without ribavirin, in naive genotype 1. Well, looks pretty good here. Looks pretty good. Now, if we look over here, this is the level of virus, and this higher level, and this is genotype 1A. And in the blue part, again, we have RAVs. Now, this is something that, as we get this group that fails, we'll have to look at. These are resistant antiviral variants. Most of the time, even when they have them, if it's a naive patient, they respond fine. But if someone fails on treatment, you certainly want to know, do they have resistant mutants? If they were on an NS5A drug and failed, you want to see, do they have resistance to it, because you want to get something else in there, if possible. In this case, they're asking you, if it's genotype 1A, to look for the RAVs ahead of time. I don't do that. That doesn't make it right, but I certainly do because most of the time they're going to respond, and even if they haven't, if they're naive. But it's something to keep in mind. It's a cost issue. Okay, now let's look here. I like this one. This one is the combination. This is a Merck combo with or without ribavirin. Treatment experience genotype 1A, and you're looking here across the board. Cirrhosis, yes. Look, this is yes, and 96% SVR. Okay. SVR 12, 96%. Over here, with ribavirin, here it really didn't make much difference in this particular situation. The duration of treatment, here we have 12 weeks, here we have 16. A little better here. Here we're talking about whether or not they have the RAVs. Here you see this is the group where many would have ribavirin. Okay, let's go ahead. This one is the one that's coming out at the end of the month here. Look at this. Look at this. This is pretty darn good. And here we're looking at SVR 12 rates, and look down here, combined data for genotypes 1, 2, 4, 5, and 6. You don't see 3 in there. But look at this. Overall, 99%. Cirrhosis, yes, 99%. Prior treatment status experience, 99%. Now that's looking pretty good. Pretty good, 99%. So you're seeing different studies. Almost all of them are over 95%. But again, the tough thing is a cirrhotic who failed previously, particularly if it's genotype 3. Okay, let's take it a little further. Here we're looking at genotype 2 patients. Now genotype 2 in the past was an easier one, but the combination of direct antivirals, you couldn't get it for 2. Well, the one that's coming out, licensed for 2, and let's look at genotype 2. Overall, the combo, and I'm talking about, it's always comparing it to this plus ribavirin. So let's look at the blue. Coming out 99%, no cirrhosis 99, cirrhosis 100%, so there's really no difference here. Treatment experience, cirrhotic 100%. So genotype 2 is going to be good with the new stuff. It's licensed for it. Frankly, what's out there now that probably would work in genotype 2, but wasn't licensed for 2. Okay, now, here is another one. This is that combination, but plus a pan-genotypic protease inhibitor. This isn't out. These are studies that are ongoing studies. And you see here, for 8 weeks, pretty good. This was done in who's been in New Zealand? This is New Zealand, FDA, and I think did this, yeah. It's a different world there. But anyway, this was for 8 weeks. Then you get into here, and in this particular one, it's naive cirrhotics, but the numbers here are relatively small. The last one there, we're talking about 8 weeks, and people who failed PEG and ribavirin who had cirrhosis 100%. So these are small numbers, but this regimen will end up being a salvage regimen. It'll probably be out in about a year. Okay, so let's look at, from AbbVie here, this combination right here that's out there right now in genotype 4 with cirrhosis. We got someone here who I know is looking especially at that. 12-week regimen versus 16-week looks pretty good. 4. So I'm trying to cover all your genotypes. 4, by the way, is primarily, it's in the United States, but primarily out of Egypt. Now, in Egypt, 15% of the population has hepatitis C. And the reason for that was there was a concerted effort to treat schistosoma mansoni, bilharzia, schistosomiasis. And they treated with injections of what was called antimonial compounds. It had nothing to do with the antimony. What it had to do with is the syringes and the needles were contaminated with blood, and they just spread them. So now they got a big program going that I alluded to in the beginning of sofosbuvir and an NS5A inhibitor, and they're doing a pretty good job. Now, what are the challenges? The challenges here are people who cannot take ribavirin. Remember in some of those regimens, you're yawning on me, I see you right back there, yawning. Okay, now, the lights are on here. How can you go out on me? Okay, now let's, ribavirin ineligible. That means, see, the payers often like the ribavirin because it's a shorter duration of treatment. Some people just can't take this stuff. So, that's a challenge. Because usually in that kind of case, if you give it longer without ribavirin, they do just as well. Renal failure with cirrhosis. Now, the Merck combo was licensed very effective in people with renal failure. That's important. And there's a host of papers coming out on that. Let's say you have somebody on a dialysis unit. You can use the Merck combo. Now, the other thing is this, that we haven't talked about a lot, but I will because we're into this, is people who are going to be transplanted or who have been transplanted. I didn't spend a lot of time on it because most of you don't deal with transplantation. There are people in here like Karen Nort, who is at a transplant center and is a transplant nurse. She probably could do the surgery. Anyway, listen. Here's the issue. Many of the livers are C positive. And so when somebody comes up and they match, it could be a C positive liver. So when these decompensated cirrhotics, many people would hold until after the transplant and then treat them. They'll respond well. Now you can make them negative before the transplant, but then you'd feel terrible if it was a C positive